In the very young child with Rett, the electroencephalogram may indicate immaturity. After the onset of regression, spikes appear centrally, then bursts of abnormal slow and sometimes sharp waves, suggestive of epilepsy but not necessarily coinciding with clinical seizures. This is a sleep EEG. The abnormality increases in sleep and diminishes on waking. Later in life, rather monotonous 3 to 4 per second theta waves may predominate. The EEG changes are suggestive but not diagnostic of Rett. Clinical epileptic seizures occur at some time in about 75%, and about half continue to have regular epilepsy. Epileptic seizures may be generalized motor or partial, but petit mal with 3 per second wave and spike has not been recorded in the UK. Epilepsy usually begins after regression and may improve in adult life. The central autonomic brainstem problem in Rett, discussed in section 3, is probably present before birth. One manifestation, the irregular breathing rhythm, usually becomes evident towards the end of the regression period, but in very severe cases is seen much earlier. This graph shows the shape of a normal breath, the rising line indicating inspiration and the falling one expiration. Several abnormal rhythms have been recorded and analysed by Julu and colleagues. This is done non-invasively with simultaneous video, transcutaneous blood gases, and EEG. Breathing rhythm becomes abnormal during periods when the individual is awake and alert. Most people with Rett switch between different respiratory rhythms without obvious reason. This child shows deep breathing, a breath hold, and a vacant spell, a common sequence in Rett. Such vacant spells are not accompanied by epileptiform activity on the electroencephalogram. The deep breathing may amount to hyperventilation and induce tetany. There are several types of breath holding. In the youngest children, this type of long, slow inspiration, apneusis, and delayed expiration are common. In older children, Valsalva breathing is common. High pressures in the chest due to unsuccessful efforts to breathe out prevent return of blood to the heart with wild fluctuations in blood gases, pulse rate and blood pressure, as can be seen here. During Valsalva breathing, there is characteristic vocalization with the forced expiration and dystonic spasm of the neck muscles, which is common. This graph shows how the percentage of apneustic breathing falls and the percentage of Valsalva breathing increases with age. Due to the forceful expulsion of air from the chest, gaseous distension of the abdomen may become very marked and cause pain. Abnormally shallow breathing is also common in the less agitated people and may not be noticed until the oxygen level falls and cyanosis or pallor appear. The poor control by the brainstem cardiorespiratory neurons of heart rate, blood pressure and breathing rhythm in Rett leads to non-epileptic vacant spells. The hypoxia can cause faints, and the brainstem instability carries a risk of cardiac arrest. Several types of such vacant spell have been described, and here is one such. This slide indicates how commonly non-epileptic vacant spells are present in the same individuals who have cortical epilepsy, although these are distinct problems and cortical epilepsy rarely occurs simultaneous with a vacant spell. Non-epileptic vacant spells are thought to be responsible for some of the 20% of reported deaths in Rett, which are sudden and unexpected. When vacant spells present serious problems, non-invasive simultaneous monitoring of encephalogram, blood gases, heart rate and blood pressure should be carried out. Other signs of unrestrained sympathetic tone are small, cold feet. The circulation to the feet has been shown to improve when the sympathetic chain is interrupted during spinal surgery. Here you can also see the short fourth toe, which is commonly seen in adults with Rett.